I'm Bernie Owen, just going to start the Environmental Health and Covid-19 session. We've got 4 talks and 2 hours, so people can try to keep to some reasonable order. I think the target is 20 minutes, but people usually overrun a little bit. The first speakers are Anne Roiko and Lachlan Guthrie, who are fortunately putting things up ready. Anne is an environmental health specialist, and Lachlan Guthrie is a water strategic planning and security person, both of them in Australia. In fact, all our speakers today are from Australia. The first talk is essentially about vulnerability to pandemics in the Indo-Pacific and a water security risk index, which they'll be telling us about. So please go ahead.
Okay, good morning, and thank you very much for the opportunity for us to present on this stuff and to have this whole session on environmental health, because to us this pandemic of COVID presents a true environmental health risk, and to have these range of presentations this morning I think gives a good perspective from different ways. This morning we want to talk about a project that Lachlan and I have been working on, funded by the Australian Water Partnership. But I'll let Lachlan introduce basically where it came from. But we'd like to be able to just cover today why we set out to develop this sort of index, which is very coarse on a country level sort of scale, but it had a specific purpose and it's got strengths that lends itself to develop further applications that we'd be keen to sort of discuss with people if they're interested. We'll explain our approach, how we tackle this sort of task. We'll demonstrate some of the results, what we came up with, and some insights about where we'd like to go from here. So I'll come back at the end and talk about where do we want to go from here, but I'll pass over to Lachlan now to actually talk through the index. Thank you.
Yeah, thanks for that, Anne. So as Anne mentioned, we've developed a joint COVID-19 water security risk index, and this has been requested and the work's been paid for by the Australian Water Partnership through the Department of Foreign Affairs and Trade. As Anne mentioned, she just ran through what we're going to talk about today, and I'll just jump in. Sorry. There we go. So firstly, what is the value of a risk-based framework and risk-based decision making? So I've got on the screen there Papua New Guinea. I'm sure we're all familiar with the country. It's just to the north of Australia. It's technically in the Pacific, but it's also on the end of Southeast Asia. On the right there, I have the number of new cases reported in Papua New Guinea. So what we were hearing through the media was that through most of 2020, Papua New Guinea was doing incredibly well. They were having very few cases recorded, but what the risk matrix we were using was telling us was that even though Papua New Guinea had very few cases recorded, they were still at quite incredibly high risk. And that is because they share a land border with Indonesia. So while there was some complacency that came in through the decision making by looking at the cases, if you use a risk lens, you would never be complacent. You would still see that it's very high risk, and that's exactly what happened. They're now seeing many new cases each day. Those cases there are very much expected to be an underreporting because they have very low testing, and so it's difficult to know how that country is actually going. But looking at a risk-based decision-making model, you would have addressed the risks a bit better. That being that land border with Indonesia. So noting, so what they did in PNG was they strengthened the air border. They had quite good controls on the checks of people coming in by plane. But up until February of this year, they performed six border checks on land crossing. So we know that border was not properly secured. and a risk-based decision-making framework would have enabled that. So what are we doing in this project? So as Anne mentioned, we were asked by the Department of Foreign Affairs and Trade to build on the Asian Water Development Outlook, which is an indexing methodology, the Asian Development Bank's flagship water security publication. And so we were asked to look at the impact that water security might have on a COVID-19 outbreak, and then also the impact that COVID-19 would have on water security. So looking at it from both angles. We developed a health risk-based framework, and that then was turned into a composite index for COVID-19, and relevant water-related factors were highlighted, sorry. And so what this allows us to do is understand the temporal relevance of different factors, and identify which of those factors were the most were attributed to the country's most attributed to the country's high risk, and then to prioritise and target water-related investment to those specific factors. So this is the team. It was myself and Associate Professor Anne Roiko. Bernie's already given us a really nice introduction, so I won't dwell on this slide too long. So the first thing that we did was create a risk-based health framework. And so as you can see, using risk at the highest level, risk is a function of likelihood and consequence. And so those formed our two sub-indices. And then we created these temporal risk elements. We took these from an Australian government response to the H1N1 virus. And what we've essentially done is you can break up the pandemic into certain phases. So firstly, the ability to stay alert when the virus is breaking out in other countries, the ability to delay the spark, so stopping it arriving in your country, containing the spread once it's in your country, stopping community transmission, treating those infected. So this is both the medical infrastructure that's there, and then also the presence of comorbidities. Then the ability to immunise the community and ability to recover. So the ability to recover largely looks at economic factors and how well an economy will respond after the pandemic. So in total, we identified 118 key factors that we considered for inclusion. So I'll just make, so in our terminology, we had quite a different definition of factors and metrics. So factors were things that are relevant, whereas the metric is a proxy measurement for that. So if you're looking at crowding, then total population density is so crowding would be the factor. Total population density is therefore the metric. So there's an important distinction between the two. So first we looked at previous infectious disease risk frameworks, and then also looked at emerging COVID knowledge and to identify our really long list of key factors. From there, we sought appropriate metrics, being very much constrained to what was available at the in a freely available database, and also at the national level. So for a lot of the factors, suitable metrics were not able to be found, and we've kept them in the list of factors to highlight the gaps that we would like to be able to fill if and when metrics become available. So what we ended up with was this nice looking risk map here, which is from our nice looking web interface. So the link to the web interface is there. If you just Google Water Centre COVID-19 Water Security Risk Index, you'll be able to find it quite quickly. On that same web interface, you can find the entire list of factors, links to the report, links to all the background data. And so through this web interface, we're trying to be as both transparent in all of our assumptions and methods, but then also making it as accessible to anyone who wants to see it. So I would really encourage anyone to have a quick look at that. It's quite an interesting little web interface that we made. So one other thing that we also did is looking at country summaries. So one of the key limitations of an international indexing methodology is that you're only looking at the country on a national level, and for some countries that's not always appropriate. So countries like India, China, Australia, you see quite a significant variance in their risk throughout the country. And so for some of those countries who were able to do some more targeted country summaries. So these country summaries will be published soon, and we've also done one detailed case study of Timor-Leste, which I'll talk a bit more about now. So the map to the right there is Timor-Leste, which is a small country in Southeast Asia. So while it looks like it's an island on this map, sorry, it's a little bit confusing. It's actually it's a single island that's shared with Indonesia. So Okusi is bordered on all sides by Indonesia or the sea, and Bernhart and Kobalima also have borders with Indonesia. So when you look at the risk map for the country as a whole, there's not a whole lot of variance amongst the different municipalities. So the municipalities that have the border with Indonesia are higher risk, along with Dili, which has the main international airport, and Manatutu and Latem, who both have higher presence of comorbidities. But when you start looking at the subnational analysis at each of the temporal risk elements, you start to be able to tell a bit more of the story. So looking at the delay, so this is remembering that this is the ability to stop the virus entering the municipality. As you would expect, Dili having the international airport is at elevated risk, and so is Okusi, Kobalima and Bobonaro, who have the borders with Indonesia. Then it's relatively the same across all the other municipalities. Looking at contain, that's quite similar. So throughout the entire country, there's some really high risks around the ability to stop the community transmission. What is probably most interesting is when we look at the treat index. So remembering that this is medical infrastructure and also the presence of comorbidities, you can see there that there's 4 municipalities that actually have much higher comorbidities than the others. So Timor-Leste as a whole has very few of the non-communicable disease problems that are comorbidities for COVID-19. They also, on the whole, have quite a young population. So in that treat index, the country as a whole does quite well. But when you look at each municipality, you can see that it's not the same. And you can see that Manatutu has much higher incidence of diabetes than in any of the other provinces. And so we can make the statement then that were it to arrive in one of those 4 municipalities, it would have more devastating consequences there. So then moving into recover, this is all quite the same across the country. Dili and Latem both have very minimal. They're just 0.1 off the score that they would have needed to be the extremely high risk as the rest of the country is. So from these country summaries, so we did another 11 country summaries, mainly through the Pacific, Southeast Asia, and then also India and South Asia. And this was able to tell us some general recommendations across the region. And so the 4 recommendations that were coming up in most of the countries were to contain the spread by increasing the capacity of wastewater epidemiology. And I'm sure Dan will probably talk about this a little bit more, but here we're noting that there is quite an important, there's multiple elements that are very important here, both conducting the surveillance, which is the technical things of sampling, storage, transport and lab testing, but then also the capacity to interpret results and communicate those with the public and other stakeholders, and then also inform your decision making. Those are 2 very critical elements of that same project. The second there is to improve washing the household. As I'm sure we can all understand, it's very difficult to isolate at home if you don't have access to water and a toilet. And so specifically in the Pacific, this is a very important recommendation. Thirdly, then, is investing in agricultural water security. We noticed that for many countries, the reduction in tourism and trade either were going to cause significant or are causing significant economic problems and also problems around food security. So in particular, the Marshall Islands is basically dependent on food imports. So the reduction in trade is very difficult for them to manage. And likewise, countries like Kiribati, very dependent on tourism. And then the last one there is talking about the capacity for water practitioners to adapt to climate change. One thing that we noted through all the country summaries is that while COVID was the urgent pressing matter, climate change in most cases is going to be a much bigger issue and needs to be immediately addressed, or there will be some very significant water security concerns in the near future. But now I'll just hand back over to Anne, who's going to talk about sort of the next steps and where we'd like to take this index.
Right. Thanks, Lachlan. I think I'd really encourage you to have a look. We'll put the link to the website in the chat, because once you go, it's very easy to navigate and you can explore the different factors and the sub-indices that we looked at. And the aim for this project was to work out which of those factors were important or that relied heavily on water. So you can imagine in very crowded places like India, if you don't have sanitation in the home and you've got to go out to get street pumps or to visit public toilets outside, you can't self-contain and stay away from other people. So depending on where you're at with the epidemic, with the pandemic, like whether it is highly prevalent in your country, different aspects of water become more and more important. And so it's really, this index was designed to support investments that the Australian foreign aid in water was directing at these countries. Where should they invest their water investments as a prioritisation? But what we could see that the real value of this really comes to, well, what we've developed the algorithm, we've got this temporal sort of element of being able to apply and identify risk factors and assess the capacity of communities to adjust to it. And we've been talking with regulators and communities within Australia that we could look at the vulnerability of, for example, rural Indigenous communities and different, we can break it down to that sub-national level is really where it could be important. And we could also go beyond, it relies on metrics, but we can look at can we use expert opinion in the place of metrics, because the knowledge development in this field of COVID is travelling so fast. In 2020 alone, there were more than 2,000 publications just on COVID. So you can imagine the knowledge is, the science is moving very fast, our capacity is moving very fast, and there'll be others in this session talking about what we can now do to detect it in water and sewage and that sort of thing, the remnants of the virus. But we'd be very keen to see if anyone thinks of potential applications of using this type of risk-based index to prioritise actions, whether it's particularly in the recovery. What are the critical factors involved of recovering from this pandemic, and perhaps this index might be useful. So we'd be keen to follow up with anybody about that. Might leave it there, and if there's any questions, we can address them at the end of the panel.
Okay. I like the rocks being a geologist in your screen.
Yeah, far north Queensland.
Okay, are there any questions anybody wants to raise? Got 10 minutes. Yeah. Just wait for the microphone to go over.
Hello, thank you for this presentation. I'm Jane from Baptist University. So I just want to ask, I kind of lost the first part of your presentation, so I don't know if you have already mentioned it, but I'm wondering, would you perhaps also include like normative part in this risk index, or that's just totally outrageous? Because when I'm thinking about it, like when we need to recover from COVID, or even when we deal with COVID, then there will be a conflict between, for example, the science approach versus how people want to be treated. For example, you mentioned Indigenous people. Maybe they just want to be left alone. But now we need surveillance because of the COVID situation. So do you think that it is necessary to include it in your risk assessment approach, or that just have to be left to somebody else to solve that? Thank you.
Lachlan, did you want to? I was just trying to clarify exactly. You were asking about the normative responses of the people to the pandemic situation. I couldn't quite. Lachlan, did you fully understand the question?
Yeah, so I think was the question about sort of what happens when we create a new COVID normal, or is that more or less what you meant?
It's more about when you create the risk assessment index, would you consider normative part to be part of the index, or it's just purely scientific? Because
it's definitely not purely scientific. It's a shame. We thought we didn't have time to sort of demonstrate the index on the website, but perhaps if there's time later, we could pull it up and Lachlan could talk you through it, because many of the factors that we looked at weren't science-based. They were actually representing things like whether the authorities have the ability to mandate a lockdown, whether people trust the health people, whether they trust their government. There's many types of normative factors and indices sort of built in, and metrics built into the framework. We'd encourage you to have a look at them and have a look at what we've come up with, because everything's transparent. You can drill down and have a look at our data and our factors and our rationale, and we'd welcome any feedback. Like if we've missed factors that are very important in Hong Kong, for example, we'd like to know about them.
So that was in particular the political and cultural factors. We noted that they were incredibly important. But one thing that was consistently an issue is that we couldn't find good metrics and that were available at an international level. So that's something that when we hope to be able to sort of do some more subnational analysis, hopefully there would be a way that we can incorporate expert opinion across these political and cultural factors, because just in the Australian experience, it's so important. The public's willingness to follow directives, which is sort of a response to how much you trust government, and then also how many political freedoms you feel you have. Super important. Potentially the most important, really, in terms of the government's being able to effectively bring in health measures.
Do you find people are able to understand? Do you find people are able to understand the risk? In Hong Kong, we have an amazingly available vaccine, but
Yeah.
going to take it because they're worried about the side effects. They should be worried about the virus. Do you,
Yeah, and that's a complacency that I've written about in the papers and Lachlan's written about in an article. Because we have such low prevalence of COVID at the moment in Australia, there is a high level of complacency, and they don't understand those concepts of risk and the very low chance of those adverse side effects from the vaccine. But
the trouble?
plus, they're getting mixed messages from the government.
The trouble for me is that I think this is a general problem. Society like Hong Kong as well, with virtually zero COVID at the moment. They don't understand we're trapping ourselves in a long-term, it is a trap, this pursuit of zero COVID. We're locked down. I can't go anywhere at the moment. If I go away, I've come back, I have to spend 3 weeks in jail.
Yes.
The same in Australia. So one thing that I often say is that before you're misinformed, you're poorly informed. And so I think it's so important that the media gets out the proper messaging. Like, of course, there's risks with the vaccine, but you're looking at sort of 1 in 100,000, whereas the risk of COVID is much, much greater.
And Taiwan's a good example where they had very, very low levels of community transmission, and then they reduced the quarantine of pilots down to 3 days, and it led to a break in quarantine, and they've got a big outbreak.
So you're in a trap. Taiwan is going through the same thing now. They've had one of the best COVID success rates, but now it's taking off. I was going to warn Malcolm that I'm about to pass over to him in a second. Any last questions?
I just see Sophie's got a question online.
I was just going to make the point, I suspect to see, there's not a question of the public not understanding risk assessment. I think they're making quite a rational risk assessment. That's the problem. That while it's not present, they're being quite rational and saying, well, I'll wait and I'm worried. You know, it's an interesting concept because there's a lot of conversation in Australia about the vaccine side effects, and it's 1 in 100,000, and the reaction of the community is, ooh, you know, a bit nervous about 1 in 100,000, which for me is, as a person who's done, you know, environmental health policy, quite an interesting observation that at the rate of 1 in 100,000, it's enough to make people step back and go, well, I can take my time and it's not going to affect me today. And yes, I know we've all got to get vaccinated so that we can open up the borders, but right now I'm very happy. So I see it as people not being misguided, but being actually quite rational, and you've got to nudge them past for the greater good. You've got to nudge them past the individual for the greater good of society, basically.
And I think also, Sophie, that they're fine now, but there will be breaks in quarantine. There will be overseas cases coming in, and we're a very naive community. We've got no immunity as a community until we get that herd immunity up. So they can't stay safe forever.
The next speaker, I'm hoping the next speaker, is Malcolm Sim from Monash University. He's an occupational and environmental physician. He's going to be talking about how you can reduce the health burden of COVID-19 in the workplace.
Okay, we all set to go?
Okay, go ahead, please.
Okay. Thanks for the introduction, Bernie, and I'm really grateful for the opportunity to talk about this really important topic in this conference, and I really wish I could be there in person. I've been to Hong Kong many times, and it's a shame I'm not able to get there this time, but hopefully not too distant future. That discussion around the vaccination and the risk benefit in a country with no community transmission is very, very topical, as Sophie has raised, and I think our two countries sort of share that challenge at the moment. But look, I'm not going to talk about vaccination today. I'm going to talk about some of the challenges we've had with preventing COVID-19 in the workplace. I know this session is around sort of environmental health, and my particular interest is the workplace environment and the risks to workers across a whole range of different industry sectors, and the importance of having a transdisciplinary approach involving a whole range of people with different disciplines and backgrounds in that response. Okay. Doesn't seem to be moving. Oh, there we go. So the aims of my talk today are to demonstrate how the health and allied disciplines have needed to increase, broaden and work better together to mount an effective response to the COVID-19 pandemic, and in fact infectious disease control in general. And I'm going to illustrate this with some examples drawn from workplaces where COVID-19 has had the greatest impact, and in particular the healthcare sector that I've had quite a lot to do with here in Australia. And when I'm talking about the health burden, I'm including not just sort of physical health, so infectious disease, but also mental health and well-being, which is a really important factor in controlling this pandemic and its burden. So I just want to sort of go back to when this pandemic first started. So this was, January, February last year, for this country and for most countries really around the world. So when this first came about, the initial expertise that was drawn upon was really focused on infectious disease physicians, infection control nurses, and public health physicians. And, while I certainly acknowledge the really important contribution those disciplines have made in the response, it became clear very early on that that wasn't enough. It needed a whole range of other health and allied disciplines to contribute to this response to reduce the spread of this virus. And the main focus initially was on reducing droplet and contact spread. And this is very much mainstream infectious disease control teaching and principles. And so the traditional infectious disease measures that were promoted early on were physical distancing. So whichever country you're in, that's 1.5 metre or 6 feet, hand sanitising, coughing into the elbow, and stay at home if you're sick. So we had a lot of promotion of this. There were advertising campaigns around these various measures on very much an individual basis to stop spread of the virus. But it became very clear early on as the cases started to mount that such measures weren't sufficient, and especially in workplaces. And I'm going to illustrate that with some information about the healthcare sector. And just a sort of graphic that got a lot of publicity in this country, in Australia, but also in many other countries overseas, similar sorts of graphics that showed, keeping apart by 1 to 2 metres was really important. So it was pretty clear to those of us in the health and safety, occupational health and safety area, that we were very likely to get a tsunami of cases in workplaces. And I wrote an editorial on this for one of the BMJ specialty journals, Occupational Environmental Medicine. I was the editor-in-chief at the time, and so part of my role was to write editorials, so I could see this. And I wrote this in March last year, highlighting the major risks to healthcare and other workers on the front line that were likely to come from the COVID-19 pandemic. So in that that stage, it was very much in its early stages, and the true impact, I think, wasn't really clear to most people around the world. But in fact, since that time, there's been a lot of publicity about the impact that there has been on the healthcare workforce right around the world. And this is a graphic from a little earlier this year. There's a website that charts, death of healthcare workers from COVID-19 from various countries. It's certainly incomplete, and I suspect the numbers are far greater than this number. But it certainly brings it home to you that people whose jobs are to go and protect the public from COVID-19 and manage them and try to reduce health impacts, death and serious illness in the community, are themselves put at risk by going and doing their work that they're trained for. And in fact, in the UK, there's much more graphic messaging is coming through. This is a graphic from, I think it's from December last year, and there's certainly the numbers will have gone up since that time. But there's again, a website that people can contribute photos to of healthcare workers who've died, and so almost 3,000 at that stage in the UK had died from COVID-19. And I suppose seeing the pictures and seeing that this really cuts across age groups, ethnic groups, genders, cultural groups, it really brings home that this is something which is affecting people and workers in the healthcare sector right across the sector. And also in Victoria, we had a well publicised sort of second wave here in my state, which was a little out of kilter with the rest of the country. You can see here, this is a chart of the cases that occurred. We had a little blip of healthcare worker cases very early on, back in March, and then things settled down through some really good community protection measures. But from sort of early July right through until late September, we had this big wave of cases, and this mirrored what was happening out in the community. We had a large number of cases and a large number of deaths from COVID-19. But this shows it broken down by medical practitioner, nurse and other healthcare worker, primarily nurses and other healthcare workers who work in the sector, often not in direct clinical facing roles. So this really brought home that the measures that we had in place to try and protect healthcare workers simply weren't working. So the government here put in place a couple of task forces in the healthcare sector to try and address this problem, review the protective measures that were in place and to look at how they could be enhanced. There had been a PPE, personal protective equipment task force that had been established in April, so well before this second wave. But on looking at that, its role was largely about procurement and supply. It was too limited in its roles and its membership, and it didn't really address other aspects of prevention that are really important to prevent infection with COVID-19. And so a healthcare worker infection prevention and wellbeing task force was established, and this brought into around the table a wide range of disciplines, certainly the infectious disease group, public health, but also occupational health and safety, the sector that I come from, and but also clinicians, engineers, aerosol physicists. There was a whole range of different groups. There were mental health experts brought in to try and address this in a more transdisciplinary way than the sort of more isolated sort of infectious disease approach that had been advocated very early on. And the aim was really to get a more coordinated response right across the sector. And it had a very wide transdisciplinary base, as I mentioned. And there were two subgroups that were put together. One was the infection prevention and control subgroup that I was a member of, to really review those prevention and control measures, but also a healthcare worker and wellbeing, because we'd got a lot of feedback from the sector that healthcare workers were really suffering, not just from in a physical way, but also very anxious about going to work, their risk of getting sick, of infecting their family members if they became infected. So this was having quite a major mental health burden right across the sector. And I suppose one of the things that I and my health and safety colleagues sort of brought to the table was thinking much more around this concept of the hierarchy of controls. Early on in the pandemic, the focus had been very much on PPE. PPE was sort of seen as the main prevention measure. But I've been trained in thinking about control as more of a hierarchy and having higher order controls, which are like elimination of the hazard, substitution, engineering controls where you try and isolate, changing the way people work through administrative controls to reduce exposure. And of course, the last line of defence is personal protective equipment. Certainly an important component, but it's not the only component. So we tried to promote the idea of looking at ways within the health sector to do elimination, substitution, engineering controls and administrative controls to enhance the personal protective equipment approach. And we also tried to promote more of a risk assessment and management approach than had been put in place before. And I've just put up here a document that the Australasian Faculty of Occupational and Environmental Medicine, which is a faculty within the Royal Australasian College of Physicians, put together. I'm president of that body at the moment, and we could see that there was a real gap in workplace risk assessment and management. So we put together a document trying to outline the principles of that for more widespread use out in industry, and drew upon that as part of the healthcare worker task force that was put together. And I think this task force was very successful. In a very short period of time, they put together a roadmap for healthcare worker protection from COVID-19, covering a whole range of different aspects. And I've just mentioned a few of these here. One was a respiratory protection program, which is really important when you're using respirators such as P2 or N95 respirators. It's really important to have fit testing, choosing the most suitable respirator for each worker, proper training, medical assessment to see if they're fit to use those respirators, and understanding around the side effects such as skin chafing, difficulty breathing that can occur through use of those respirators. We also found that the data around the infection showed that a lot of the infections weren't occurring in direct patient contact, but when people went to tea rooms, change rooms, and so on. So we put together an amenities guide around reducing exposure in those non-clinical settings. And we also started to do some work on the ventilation flow within hospitals and other healthcare facilities, which really showed that aerosol transmission was a greater factor than had been thought about before. The task force put together a mental health toolkit to assist workers in mentally preparing for the COVID-19 pandemic and risk of infection, and a healthcare worker mental health and wellbeing centre has been set up to continue that work. And I suppose being part of this task force, what it demonstrated to me is that the healthcare sector here in Victoria, at least, had a pretty low level of understanding of occupational health and safety principles in hazard protection for their workers, which I think goes far beyond just COVID-19 protections into other areas as well. So just to remind you then how effective this was, I mean, this mirrors again the reduction in community transmission through quite a long-term lockdown that we had, but there were also much better measures put in place in the healthcare sector, in particular in hospitals, to reduce those infections amongst healthcare workers. And these dropped off, and by sort of very late last year were down to negligible levels, whereas they'd been up to quite a few hundred per day. Now, I just want to spend a few minutes talking about this debate around aerosols versus droplets. I've talked a little bit about this as part of the work of the Healthcare Worker Task Force, but there's been quite a debate here, and I think in most countries around the world, about the relative contribution of aerosols and droplets. And this sort of stems from some fairly traditional teaching in the infectious disease world about kind of two categories of contaminants. One is this droplets, which are larger particles which go from a source, a person who's infected, and drop to the ground very quickly. And then this other group that is seen to be much smaller and can travel distances and infect people further away. But in fact, the reality is that there's quite a spectrum of particle sizes. It's not two groups like this. It's a spectrum, and you can and a lot of this modelling work has now been done. And aerosol physicists have looked at the particles that are emitted when somebody sneezes or coughs or even talks or sings, and you can see that there's quite a range of different sizes of droplets, which some drop quickly and others travel further. So I think it's now become much more widely accepted that there is aerosol and droplets kind of occur together and aren't just two categories. And I think it's best to think of this as a continuum with a spectrum of size depending on the circumstances. And airflow and ventilation rates have been found to be really important in trying to control that aerosol source of transmission. The other major debate that we've had is around surgical masks and P2 or N95 respirators, and I've just demonstrated the two different types here. They may not look that different, but in fact they've got quite different standards that they need to live up to in terms of protection of healthcare workers. And there's been a huge amount of debate about whether P2 or N95 respirators are needed in healthcare workers. We've advocated that where the risk assessment shows that there is quite a risk from aerosol transmission, those respirators are needed and offer much better protection than surgical masks, although a lot of the epidemiology evidence hasn't really supported that as yet. And the use really depends on the risk assessment. And if these are needed, it's important to remember that P2 or N95 respirators are a respirator, so they need a respiratory protection program with fit testing and those other factors that I mentioned before that we developed as part of the Healthcare Worker Task Force. I'll just mention one other thing before I move on briefly to the next topic. There's quite a lot of work done here in Victoria in one of our hospitals, the Royal Melbourne Hospital, where the medical sector worked very closely with some mechanical engineers and aerosol physicists to try and develop this concept of this higher order control of isolation. And they were very successful in developing these ventilation hoods, in particular for use in intensive care units where the healthcare workers were in very close contact with COVID patients. And this was developed and trialled and found to effectively reduce the airborne contamination around these patients. And this demonstrates one of those with a patient there and some healthcare workers. This was also picked up in one of our newspapers here, the Herald Sun. It was called the Hood of Hope for COVID-19 patients. So this really captured the imagination. And I think this is something that's going to come into more widespread use for any patient with an infectious disease who's being looked after in intensive care. So this shows the importance of thinking about those higher order controls of isolation of these patients. And I just want to move on from that to show some of the other work which has been done looking at dispersion of particles that's been done in the Royal Melbourne Hospital. This is a graphic which shows what happens when you've got a patient in a room in a hospital, and you can see that there are various small particles that are generated. If the door is open, those particles can go out into the hallway, and if the extraction fan for the ventilation system is set some way down the corridor, which is often the case in hospitals, you can see that those particles can come, they can disperse into other rooms if doors are open before getting to the exhaust for removing them from the air. And what I've shown here is if you have a hospital desk where a ward clerk or nurses might be sitting, if they're in the direct pathway of those particles, then they can certainly be at risk. And so this shows the importance of, situating those staff in an office environment, ward clerks, sort of away from the flow of those particles. And there's been quite a lot of work done now there to change the flow or change the situation of where the staff sit. So this again has been another really good example of some aerosol physics work demonstrating risks to healthcare worker staff and ways to try and mitigate that risk. Just the last thing I'll talk about is some of the work that's been done here, looking at some portable air filters. So these are HEPA filters with high efficiency particulate filters in them that can be put into rooms where COVID-19 patients are. This is done with a surrogate of air contamination smoke, but it's got a very similar size distribution. And this shows the red line. If you just rely on the standard air conditioning in the hospital, it can take about 60 minutes to clear that room once the source is removed. But when you put in some of these portable controls, you can see that goes down to 10 minutes or so. So this shows a drastically increased reduction in the exposure time for any staff who might be working in the area. So these have now come into some fairly wide use in the healthcare sector and other worker sectors as well. So again, this shows the importance of the medical disciplines working with the engineering and aerosol physicist disciplines to come up with solutions for COVID-19 transmission. And look, we developed other higher order controls as part of the task force, cohorting of patients, so putting patients together so you have fewer staff who are coming across them. Negative pressure rooms, monitoring equipment outside patient care rooms where possible, minimise time in direct care, and having staffing changes and bubbles so you have the same group of workers working on the same shift all the time. So if one of those becomes infected, they only have the potential to affect a smaller number. So these are some of the administrative higher order controls that were put in place, and there were many more. I don't have time to go through all of those today. Just briefly to mention some other high-risk industry sectors that we found here in Australia, where we've applied some of these techniques to higher order controls. The residential aged care sector has been a really important one. Many of our deaths here occurred in the residential aged care sector. And a key factor here that was found early on was this problem of precarious employment. This is where people are in casual work arrangements, which forces them to work at different workplaces. So they're moving around, they get infected at one, go and work at another aged care facility, and so infect the patients there. So there have been steps put in place to try and reduce that precarious employment problem. Again, a higher order control. The meat industry was also a major problem here and has been in other countries elsewhere, in particular the US. There are some particular aspects around temperature and humidity in that industry, which promotes infectivity. Also was found that close contacts outside the workplace, so people travelling in cars together, living together as well. And there are a range of sort of cultural factors that came into place there because it's a large migrant workforce. So again, needed people with expertise in occupational hygiene, in cultural understanding to try and get those messages across in the meat industry. And the hotel quarantine area is, as we've reduced our community transmission, has really become a flashpoint for cases here in Australia. And there's been a lot of work done on breaches that have occurred out of that, and aerosol transmission is clearly the major factor which is causing those breaches and escapes from hotel quarantine. And I think the major message out of this is all of these have required a wide range of disciplines to try and target and identify the sources of transmission, and then to put in place the effective controls to reduce those transmissions. I'm going to finish off just with mentioning a couple of studies that we're doing here. I don't have time to go through these in great detail, but we've got some funding from our state health department to set up the COVID HA study. This is COVID in Victorian healthcare and aged care workers. We're recruiting 1,500 workers into this from both of those sectors and monitoring over time their physical and mental health outcomes. And in particular, we're interested in this problem of long COVID, where people have persisting symptoms after recovering from the acute effects of the disease, and also the mental health outcomes. And we're also looking at workplace preparedness to try and improve that for the next time we have a pandemic or the cases start to increase again. And that's just getting underway. We're just going through the recruitment at the moment. The other study I'm involved with is a cohort study of health and work changes from COVID. And we've recruited online 2,600 participants from around Australia. And we're looking at the impact of people who've either lost their job or had reduced work hours. And we've found poorer mental health for those who've lost their job completely, but some recovery following return to work in some of the follow-up work. And we've had our first paper published on this recently in Journal of Occupational Rehabilitation. We've just submitted a paper on some of the follow-up work as well for those who are interested. So just to finish off with some key messages, I think that the COVID-19 pandemic has identified many deficiencies in infectious disease response from some of the traditional teaching on this, and a greater recognition of the role of aerosol transmission compared with droplet contact. The hierarchy of controls and risk assessment are two techniques that now I think are in much more common use, that weren't as prominent as they were before. And those higher order controls need to be applied in conjunction with suitable PPE. And I think the biggest message for the purposes of this talk anyway today is the major need for these transdisciplinary teams. The health sector needs to work with a whole range of other disciplines outside that sector in the COVID-19 response, but also for future pandemics. We're pretty sure that COVID-19 isn't going to be the last one. We're going to have more of these in the future. So we need to be much better prepared for those than we were for COVID-19. So I'll leave it there, and thank you for your attention, and I look forward to questions and some other panel discussion. Thank you.
Does anybody want to ask a question? There was a question from on aerosol transmission and management. Aerosol, the news you said give us about aerosols being moved. Do you want to follow up on?
There was a question from me, Malcolm, about whether you could comment on whether we can make hotels safe for quarantine, given that they have a reliance on air conditioning systems, or should we just be going full flog developing special quarantine facilities?
Oh, Anne, was that you?
Yes.
Yeah. Oh, okay. Yeah, well, hotel quarantine. Boy, this has been a really big issue here. And I was on the recent review that Alan Cheng led, who's the Deputy Chief Health Officer here, looking at the latest breach that occurred a little earlier this year, causing hotel quarantine to stop and international arrivals to stop. Look, there are a range of issues there. One was certainly that it became very clear hotels are not designed for this purpose. They're not designed for long-term people to live in them. They're not designed for infection control, and the ventilation systems are there for comfort, not infection control. So they're quite different from a hospital environment. Yes, look, there's been a lot of work done to try and improve that to greater or lesser degrees. I mean, some of these hotels are pretty old. Some of the HVAC systems are pretty old as well, and you can only do so much. So I think now hotels really have to meet certain criteria in terms of negative pressure, in terms of their air exchanges per hour and so on, to make them suitable. But the reality is you're never going to be able to stop all escapes of infection from that. They were set up as a temporary sort of measure when quarantine was needed, and all these hotels were empty because we didn't have any tourists coming in. So it was a good short-term measure, but it's certainly not a long-term measure. And I think what we'll end up with is a range of different quarantine facilities, you know, the Howard Springs type situation. Victoria's looking to build one of those, which is a sort of flat quarantine station rather than a high-rise one, but also home quarantine for vaccinated people, I think will come in place at some stage in the future as well. I think that's got a long way to play out yet.
Okay.
So the next speaker is Sophie Dwyer. She's an adjunct professor at the University of Queensland. Particular speciality is public and environmental health. And I'm going to talk about environmental health sector, how it's responded to the pandemic from a Queensland perspective. So if we can get Sophie ready.
Thank you. I'll just share my screen. Hopefully it'll work. Actually, it works quite well following on from Malcolm, because I pick up on some of your issues a little bit in terms of applying those concepts in other settings as well. So this is a presentation about personal reflections being involved in the COVID response here in Queensland until I retired about 6 months ago. So I don't represent, it's not an official position of any organisation, though, and I'll try not to give away too many official secrets, but hopefully you'll get a touch of what was the practical behind the scenes application of the science that Malcolm was talking about in Queensland, and particularly the role of environmental health officers and parts of the department. So just to cover what are sorts of components of everyone's response, which probably same in all countries. Obviously, the heart and soul of this is the classic disease control response around contact tracing, identifying cases and following up and isolating people. Now, I pulled out isolation and quarantine because there's quarantine preventing people coming into the country. There's also isolation of cases and contacts, but that had its own risks associated with it. And I will talk a little bit about the role there. And it really flows nicely from Malcolm's comments. The whole testing and surveillance, there's the testing of the public, but also wastewater. And I know Dan D is going to be talking about wastewater surveillance and how that has come through as a tool in the overall package of responses. And clearly clinical care of patients, vaccination of clinical care of those who've got ill, and the groundbreaking work that's been done all over the world around there, and vaccination to stop the spread of disease. But around the heart of this was the experience of everyone in Australia and all around the world, and where a lot of the policy debate is actually around community business controls. And this is also where you found environmental health officers, and this is also where I spent my time doing a lot of negotiation work around the community and business controls. So why am I focusing on the environmental health officer skills? And it picks up on Malcolm's point about multidisciplinary. We see it as a medical problem and a nursing problem. And in terms of infection control and disease control and outbreak control, obviously they're critical. But when it comes to trying to embed in the community a wide range of controls on everyday behaviour, it's about applying the science that's coming out and then instituting legislative and other measures to limit or to place constraints on what people do. Now, it really straddled both occupational health and safety and environmental health. So in Queensland, it was a joint effort with the health department and the workplace health and safety staff, and really across government. Now, where the environmental health people are very useful is that they have general public health knowledge. It's probably where they offer something special when you compare with the occupational health and safety training. They're training in microbiology and the application of risk from a health point of view, and putting in controls to stop the spread of the risk, and the use of legislation to control that risk is a bread and butter work. And they apply that sort of work in areas like general sanitation and hygiene, very traditionally, food safety, drugs, poisons regulation, infection control in the community sector like beauty therapy and tattooing and all of that, personal appearance services. But they also are good at risk assessment. So their job is often to act in an advisory function where they do risk assessment. So we have a large cohort of those staff across Australia, both in the state and local government level. And they were brought to bear, everyone was brought to bear to work in COVID in one way or another. It affected every part of society, but in particular, in terms of coordinating and leading this work around changing the environment to reduce the risk of spread of disease as much as feasible. It was also, this work was fundamentally multi-agency, where we all learned that, and we've always known that public health and environmental health is fundamentally a whole of society endeavour. Always has been. Not always understood by the rest of society that they had a public health role. And COVID brought it to their fore, loud and strong in front of them. And so you spent a lot of time working across agencies, as everybody had to roll up their sleeves and do work, but also needed to coordinate between policy agencies, for example, responsible for sports. We had a conversation about the Olympics and sports controls, or the agency, Place Health and Safety Agency, Education Department, Tourism Department in Queensland, small business, etc., etc. All those agencies responsible for maintaining the well-being of that sector and developing public policy around it really played a critical role. So our job in health was really excuse me, to act as a coordination point between them. And that's not unfamiliar for environmental health. So excuse me while I have a cough, I'll just mute myself. You'll be pleased to know I have had a COVID test and it's negative. I'm just having a classic cold. Can't believe I got one. Okay. So first off, the role in quarantine and isolation. So rapidly, when COVID emerged, the Chief Health Officer in Queensland very rapidly moved to isolate travellers from China before the Commonwealth government stepped in. And they were isolated at home. We used our public health legislation to do that, and it was the environmental health officers who were used to using that power who were brought to bear in that effort to actually put people in their home. We brought in services around them to help support people in their home, and that was the early stage isolation. And that then moved on to inspection of quarantine sites when they were formally established, like the hotels, and where problems emerged. It was often a joint effort with environmental health, who knew how to investigate the environment for failure, with workplace health and safety and infection control people to try and figure out what went wrong. Also had a particular role in approving specific quarantine arrangements. This emerged. We had a lot of cross-border internal borders put in place, so that if you're moving from New South Wales to Queensland, you had limits on you, and then special arrangements were put in place for like seasonal workers and sport. It seems like sporting teams got a big way forward on that. Anyway, the environmental health people would do a lot there. But so that had to apply all that knowledge. And I think that at the time, and it's only now work being done by people like Malcolm and also people here in Queensland about the role of aerosols and how really to apply that in this environment has been extremely difficult. When everyone kept saying that was not a significant factor, but you know, there was a gut feeling, you know, from experience that this was clearly a problem, and I think that's been demonstrated. And our knowledge of other organisms, knowing that they aerosolize and hang around for a period of time, we, you know, took a more conservative approach. I might actually make the observation that just following from the comments we had about aerosolize, that really it demonstrated the poor standard of air quality engineering in the general environment for air conditioning, and that the building construction industry had a significant influence over standards such that they have not ever been that great in terms of fresh air quality or air quality in air-conditioned environments. We knew that from smoking, and we've known it for years from smoking, and really had significant debates a long time ago. But now it's emerged that COVID as a factor in COVID. I think that there is really that gap in knowledge, or that work really needs to be done around. Continue to be done, and then challenge air conditioning standards across the world. We draw a lot of ours in Australia from the US. Okay, so then really the bulk of the work of the environmental health officers was getting community and industry to take measures to reduce the likelihood of spread. We worked this around COVID safe plans, what are called COVID safe plans, and there you can see a list. Very diverse group. I haven't listed them all. A lot of sensitive negotiations around them. They were developed by really in a three-way process with the industry, with the relevant policy agency, and ourselves in environmental health. Not the communicable diseases guys, they were too busy doing outbreak control. So really it's the environmental health guys and myself doing a lot of the negotiations around what would be the rules in place in these settings. And they were put together in COVID safe plans. We also had particular site-specific, they covered the whole of industry, so the entire hotel, pub, club industry had one plan. And then we also had some site-specific plans for quite unique environments like our big stadiums and convention centres and theatres and the like. We also have a mechanism for approving events, which often would be much more flexible. They could apply those broader plans that were already in existence, or they needed to do a specific event plan. So they sound quite a mechanistic process, but they really are the heart and soul of applying the science, as you know it at the time, to an environment and negotiating through with stakeholders what controls are put in place. They're extremely political in nature, not political as in, there's a lot of public policy interest, put it like that. Obviously ministers were very interested and were very concerned about how the controls were working, would take an active interest right across government. So in that sense, it was a highly sensitive process to be involved in. Mind you, you'd have some funny negotiations after getting on. We had a prostitution plan even, and I think after I just finished a conversation with them, I had to get on with the churches and have a negotiation with them. So that was ironic, really. But so just what's in those plans are obviously covering the scope, but the general hygiene, sanitation measures, cleaning, in particular. Was a factor, availability of sanitizers, etc. So that's general hygiene and sanitation measures. An important part of patient a patron registration system, knowing who's there. And I remember early on having a conversation with the Chief Health Officer about hairdressers and the beauty industry, about whether we had a full isolation early on. And as we started to open up, do we have limits of how long patrons could be in a place? And then we had to apply the science. So, well, if you're in there for 15 minutes, you're going to get exposed anyway. You can't have half a haircut. So we moved to patient registration as a second line of defence, or third or fourth really, but as a line of defence, which is, we know that transmission would occur in that setting, so patient registration, patron registration is the only way to go. It's been very important in our outbreak response that we actually find people. And there's lots of interesting, I mean, everyone developed up apps and things. There's issues of privacy that had to be applied in that setting. And we've now moved to universal apps in most jurisdictions. But early on, they were set up by the businesses and everybody had to sign in. Amazing how good people have been, actually. By and large, it's worked very well and been very important in our outbreak control. The big critical issue was patron density and social distancing, how many people to have in a space, indoor versus outdoor. Obviously, the more people you want in the place, the better it is for a business. And there were some very tense conversations about what could and couldn't be done. There's also controls on specific activities, dancing, singing, consuming a beer while standing. I didn't know it was so important to the community of Australia that they stand up to have a beer. But somehow when that actually was put in, that they could then resume standing up rather than sitting down to have a beer, we got them to sit down so they wouldn't go wandering everywhere and limit the numbers because you limit the seat. Anyway, there was great celebrations. But anyway, one of the hardest negotiations with the community choirs, where you had to say there was absolutely no way that there was not a significant risk. We knew that the epidemics, the outbreaks that had happened in various countries, including in Australia, did have a significant element where singing was a factor, or some outbreaks at any rate. So we knew that a choir would spread it out over an environment, and Malcolm's conversation about aerosols just explains that. But it really, you're talking about people whose social lives were so constrained and they're isolated. So even though they could go to the pub with their friends, really they built their life around going to their weekly choir session, and they couldn't do it, and community connection around community events was limited. So it was very hard to have those conversations at times. Sometimes there were need for quarantine requirements, as with sporting clubs who move from state to state. And obviously there's a general overarching workplace health and safety requirement, but our law has a general overarching responsibility with guidelines, which is not quite the same as our public health approach, with quite specific controls. So just some of the issues that came top of mind for me in creating these community-wide efforts was it really involved whole of government, because every part of society was affected. So whether it be the caravan park or the pub or the local, in your shopping centre, everyone was affected in every part of their work, including the home. The speed at which this all had to be done. I mean, we developed a legal framework that I would normally take 5 years to develop at a minimum. So you're making policy on the run. Wasn't too bad, all things considered. But it really meant that you got caught up. All of the things that policy development is normally a systematic process where all of the inconsistencies and errors and problems get emerged during the policy process. Well, you didn't have a lot of time for that, and then so you make a framework up, make some decisions, and suddenly something would pop up on the side that you hadn't thought about. And then you'd have to amend things. There's a lot of churning. It's all about relationships. There's extraordinary cross-agency partnership in Queensland, and I assume in other states. I can only speak for, and across states for that matter, but particularly sectors, industry, community and government working together in Australia was very strong. Bureaucrats working, not letting boundaries get in the way. But in doing so, you understood this, but the level of denial, it won't happen, it can't be that bad, do I really have to do all of this stuff? And through no fault of their own, it's not like you're picking up an industry that's, you know, like a tobacco industry or something where you're actually wanting to be punitive. These are people just trying to get on and make a living, and you are having to say you're going to have to constrain yourself. And that was just hard to see and work through, and you really wanted to let them do as much as you could, but you had to counter it with what was likely to cause harm. For some, there was a denial of the risk because it was too hard, the personal consequences too hard. And then there's this language that you hear, learning to live with it. And I've yet to figure out what people really mean learning to live with it. This is an acceptable number of deaths. I think now with vaccines, learning to live with it is going to mean we will have small outbreaks that aren't as serious as they could have been without vaccines, and that we're prepared to accept a small number of outbreaks. But Australia and Queensland got to the point of saying learning to live with it actually meant we weren't prepared to have outbreaks. So we would suppress an outbreak and not allow a bubbling level of COVID to keep going. There's a bit of overconfidence, particularly in the first wave. That was all under control, and every time you get through a new breakthrough, as we have with vaccines, everyone thinks that's it, I can go back to normal life. I think people are getting a bit more cautious now. The advocacy, the amount of advocacy behind the scenes, the sporting, professional sports being an extraordinary industry of being able to promote their own self-interest more than anyone. It was extraordinary. I've never seen anything like it, but it goes to Australia's culture. The challenges in applying science, we desperately need information on aerosols and air conditioning in reducing risk. Would love to have applied some of that science to how do we work theatres better so that the people could shout out and the airflow wouldn't drive it across the theatre. But they weren't able to answer that quick enough. But you applied what science you had, and it did evolve over the time. Finally, success in technology. Amazing that we can use all of these technologies, as we did, ran government in Queensland via the use of Zoom and all of that, and still were able to build effective working relationships, which I thought was really interesting. Just from a legal point of view, everyone says, well, you know, we'll educate, and I get that. And then as soon as something goes wrong, then they want you to pounce on people and throw the book at them. And this is a naive approach that often people take, oh, you know, we don't want to be too hard on your butt. Until it then goes wrong, and then they say, well, why didn't you go out and enforce it? And you say, oh, okay, whatever, we'll do that now. And then that's where the environmental health officers actually are quite astute in applying judgment in their enforcement work where the risk is high, and educating and using, we have a thing called a bluff act in Queensland, everyone has it, where you use your influence as much as your toolbox of regulatory instruments. And finally, in Australia, the most notable thing is generally the widespread community support for all of these constraints on liberty and industry, which surprised us. The amount of compliance where they understood and thought was reasonable. And perhaps this is my observation in Queensland, I can't comment on other states, was extraordinary. And in that sense helped get the results that we've had in Australia, where they're quite happy to support the government's move to limit, you know, for quarantine, border controls, registration upon entry of businesses, etc. Thank you.
Okay.
And that's
Any questions from the audience or online? Okay, I had one thought. Different places have different policies with regard to quarantine and so on. How much quarantine is enough? In the UK, it's either 10 days in a hotel or 10 days at home. In Hong Kong, if I go from UK to Hong Kong, it's 3 weeks in a hotel. If I go from France, it's 2 weeks in a hotel, even though UK has less COVID than France. So it seems to be worldwide confused to me. How much?
yeah. And now I suppose that's where the scientists need, the epidemiology is needed. We worked on 2 weeks. Australia works on 2 weeks on the basis that most transmission occurs. I think there's been one case recently which popped up after 2 weeks, but more likely you will see it within the first 2 weeks. So they're quite prepared to accept 2 weeks with testing. Your second comment about home isolation versus quarantine in the hotel. Early on it was home. But when they did a survey of the proportion of people complying, it was quite low, and there was a lot of breaches of people going wandering or not being at home because of, they wanted to get out to their jobs, or they want to see people, or people come and visit. So it meant that you find it's all put into hotels. Now, whether we continue to do that once we have vaccinated people will be a different thing, or whether we can use technology to keep people in their home and accept the risk of a small number of people visiting might occur, and that's probably not much of a problem. But the issue of home versus hotel, I think early on, I remember they did a survey and it was like 20 to 30% weren't home when they were meant to be. We had phone calls going in every day. And so after that, it was a sort of, well, that's not working, but we'll make it hotel quarantine or supervised or secure quarantine.
Okay, I think we'll come to the end on that one, mainly because Dan Deard gave me a very good link by pointing out that Hong Kong is more scared of me than of Australians, so the UK than Australians. If Dan can get ready to get going, he's a water quality scientist working in the Water Research Australia Colossus project. I'm not familiar with that. And he's going to talk about the very pleasant topic of sewage surveillance. Very pleasant, but one of the more important things, I think we've done a little bit of sewage surveillance in Hong Kong. So if we can get Dan into the act.
Yeah, there is an active sewage surveillance program in Hong Kong. The Environmental Protection Department's been running one for quite some time with the Drainage Services Department and Hong Kong University. So we have been discussing the programs that is being undertaken in Hong Kong. So I was in fact hoping to spend time with the group back in January, but I got a visa from the Hong Kong government, but I couldn't get a permission to leave Australia. And I still don't have permission to leave Australia even now. So I've been trying to get into Hong Kong since January, and I still haven't got the approval to leave Australia from the Australian government, but I do have approval to come into Hong Kong. So I might see you sometime in the next few months if I'm lucky.
Didn't know you needed permission to leave Australia.
You don't normally, but under the current circumstances, you can't board a Cathay flight or a Qantas flight without an approval to leave from the Australian government. Yep.
Okay.
So I'll just give you a quick summary of, I sort of start up a bit of history because I think it's always good to look at the history and see what we can learn from history. And this is just a summary from an extract from the World Health Organization's Global Polio Surveillance Action Plan summary that was issued a couple of years ago. I haven't read it out, but it's just got a section here, environmental surveillance. And environmental surveillance in this case is referring to primarily to sewage testing. And it's just one part. As you can see, the 6 components. It's one of the 6 components that's being used in the global polio eradication program. And it's been going on for about 70 years. So testing of sewage, actually for disease control or informing disease control, is not a new concept at all. It's well established. It's largely been used for diseases that are not common now in countries like Hong Kong, but it's still very important in countries that have endemic polio and other diseases. For instance, typhoid, this is an example from a paper from the 1960s or 1950s, I'm sorry, from the United States, looking at how typhoid tracing was used in sewers back in those days. It's still used today in places like India and parts of sub-Saharan Africa as a routine technique to follow typhoid cases and follow the spread of typhoid. And in areas that don't have sewage, that are using open defecation or use other types of toilet facilities, the wastewater and the environmental stormwater is used rather than the sewage itself. And so hence the term environmental surveillance or environmental epidemiology is often used rather than sewage surveillance in the context of a country like Hong Kong or Australia that has full sewage systems across the whole area. We would tend to use the term sewage surveillance. The United States uses the term sewer shed surveillance. So, but it's essentially the same thing. Now, this was actually used in SARS-1. You're probably aware of the detection of SARS-1 in the aerosols in Hong Kong and the Amoy Gardens outbreak. But it was also used to look at hospital sewage samples in Beijing. And this is an example from a paper published in 2005 from concentration and detection of SARS-CoV-1, as we now call it. And the methods used are exactly the same as methods we're using now. An electropositive filter is used. We now tend to use electronegative filters, but that's a minor detail. With reverse transcriptase PCR was used to detect and sequence the presence of the virus in sewage. And there's currently a program. We saw a presentation recently at the Global Water Research Coalition. There's currently a program across China undertaking sewage surveillance in China. As I mentioned before, there's also a program in Hong Kong run by the Drainage Services Department with the Environmental Protection Department. So Gary Liu is the main person running that program in Hong Kong. So I'll give you an example from Australia. The Australian program is very similar to the Hong Kong program because we have quite low caseloads. So I'll give you a summary of our experience in Australia. The first thing to start off with is to point out that a lot of Australian labs already had experience with sewage testing. And that's important. You can't just go from zero to having a virus lab set up. We were fortunate we had 2 labs in Australia, Sydney Water Laboratories, which is a government lab, and a private lab, ALS, in Melbourne, that had routine testing for viruses taking place on a daily basis. They tested a full range of viruses, not including coronaviruses, but a full range of viruses using a range of methods, including molecular methods, PCR methods. Plus, there were many university groups and research groups that also undertook testing for viruses without accreditation, but they were doing that. And the reason we did that was because in Australia, a huge amount of sewage is recycled. And if it's not recycled, it often ends up in oyster growing areas or bathing areas. And the environmental health professionals want to know, will that impact the oyster growing industry? Will that impact people where people swim? Or will the recycled water impact food safety or public safety? So this is an example of a report from 2016 which collated and analysed the sewage pathogen monitoring data that had been collated up until that point. But this data largely came from routine programs that are required by health departments or environmental agencies to measure sewage and measure pathogen levels in sewage, including viruses. So we had a long-standing history of measuring viruses in sewage for other reasons. There are also some researchers, for example, this is a paper from Jennifer Lund's work. She's now moved to Germany, unfortunately, but she was a great researcher at the University of New South Wales who ran a collaboration with Australia and New Zealand looking at norovirus and methadenovirus over many years, and this program is still ongoing in Australia and New Zealand. And every year we get a new sort of pandemic wave of adenovirus and norovirus come through. And these groups take the sewage and they sequence the viruses. This is a summary of a fact sheet document that describes it. And this is an extract from a paper. So again, we had a lot of familiarity with testing sewage to inform health departments about what was in the sewage and sequence the viruses and describe what types of things were in the sewage. Most of this work is not published because it's not interesting enough to be published. Unless you find a novel recombinant strain of a virus or something new, it's not usually published, but the routine programs are taking place to this day. So I'll talk briefly then about what we did about SARS-CoV-2. It was actually triggered by inquiries from China. I've done a lot of work with the Chinese Centers for Disease Control and the Chinese Ministry of Construction. And the Chinese Ministry of Construction regulates the water suppliers in China. And the CDC, of course, is the health agency. They contacted us in January last year, 2020, and asked what we knew about the implications of this virus in water and wastewater. So I contacted Sydney Water and other researchers that have virus testing capacity, and we collated their feedback into a fact sheet, which we submitted to the China Centers for Disease Control. And then we turned that into an Australian fact sheet, which is, we did a version in February and a version in March last year, which summarized things like occupational risks, working with wastewater, disinfection of water and wastewater. But right at the bottom, we had a little research section. And in the research section, we mentioned the need to run a program that would look at testing wastewater for the virus. Now, most of this research was internationally generic, and we decided we wouldn't do it. We'd let the French do it, and the Spanish and the Italians, because they had a lot more virus than we did at the time. By the time we were writing this fact sheet, Italy was full of virus and Spain doing a lot of this great research that needed to be done. But we couldn't ask them to survey our own sewage. So we decided we would start a program to test sewage for the virus. So we set up a collaborative project. And as Sophie said before, it's very important to have multidiscipline collaboration. And in a pandemic, we haven't got time for the usual bureaucratic and intellectual property delays. We have to put those to one side. And we were fortunate enough to have a professor of epidemiology from Canada send us a copy of the Canadian Water Network collaboration principles they were using for the Canadian sewage surveillance program. And we stole those and we used the same framework. And they were about having a collaborative program, having the end user, which is mainly the health department, focus our research. So we focused on the need to support the pandemic, have open sharing of ideas, but also open sharing of results. And we got these principles signed up to by universities and often private sector research labs that normally compete against one another and don't share intellectual property. They normally keep it hidden until they can publish or patent. We got them to agree to share it, and we got a great collaboration between those parties to share, to get rapid multidiscipline collaboration to help respond to the pandemic. This is a summary based a bit like what Sophie showed earlier. It shows that when you deal with a pandemic, you've got the border controls, which are the main barrier in places like Hong Kong and Australia that are islands that can control travel. You've got contact tracing to follow up cases, and you've got your isolation methods. We talked about all of those things. Sewage testing is one type of testing that sits in the bigger picture of testing, but it's probably the least important type of testing. So there's, testing of patients is obviously far more important. What it meant was very difficult to get funding for sewage testing because all the funding was being focused on clinical testing. In the United Kingdom, for example, we had a lot of meetings with the University of Sheffield and some other Bangor University, University of Exeter. They were keen to do this work, but all their molecular biology equipment had been taken from their labs and put into clinical labs. They were not even able to do basic environmental microbiology testing. In Australia, we didn't have that problem, so we were able to do sewage testing because we didn't have the problem of running out of equipment. It just took a while to get funding, but the state government health departments provided the funding. So in Australia, it's a bit like China or Canada. You've got lots of provinces and states, but we don't have a very good central system for health. The system is largely done by the state departments. So the sewage testing is a state-based program. with national collaboration between the states rather than being funded by the national government. The other thing that we were concerned about originally, our focus was on sewage, was on stool samples. We thought we'd miss the outbreaks because this is a respiratory virus. But experienced virologists pointed out that in fact, a lot of things end up in sewage. So when you brush your teeth, for example, when you wash your hands, you wash your clothes. People who, the Muslims use nasal irrigation before they pray. For example, people sing in the shower, as we heard before from Sophie, people sing and they expel lots of virus. So the University of Melbourne did some work looking at this, showing that, in fact, you get a huge amount of virus being shed from all these different pathways. What that means is wastewater actually collects virus from respiratory as well as the fecal shedding. This shows a summary of typical shedding patterns from humans from some early work undertaken in China in 2020 in hospitalized patients, showing throat swab positive in the first few weeks. So the scale here is 2 months, and then fecal positive in the next few weeks. And it shows the pattern of shedding changes. But we still get the virus coming out of both ends of the system, and both of those excretions will end up in the wastewater. But the virus is very unstable. We couldn't look for infectious virus. We couldn't find it in sewage. And in fact, after about 48 hours or 2 days at normal temperatures, we couldn't even find the RNA of the virus. So the virus is a structure that has RNA inside, which is the genetic target. The virus breaks down very quickly. We get fragments of RNA that remain maybe for a couple of days at the most. So that means it's very hard actually to find the virus, whereas poliovirus or typhoid, other viruses, adenovirus, norovirus, they last for weeks in the sewage. They're much more robust. So it's actually quite hard to test for this virus in sewage compared to other viruses. So our testing regime had to be modified to be much more efficient. Nonetheless, there is a cost benefit. So Greg Jackson, who works with Sophie Dwyer at Queensland Health, talked about how, from a cost perspective, it's cheaper for health departments to test one wastewater sample to represent up to about 50,000 people per sample, rather than one individual where you get one person per sample. It's about double the cost per sample to test wastewater, but you get up to 50,000 people represented per sample. So you can see quickly the cost benefit works out well. So I'll just run you through very briefly the process. We have a sampling process, a lab process, then a health response and a communication process. So I'll run through it briefly. In terms of sampling, the first thing we have to work out is when to sample. For most of our systems, we get a morning peak, a morning flush. So we sample in the morning, but at mining camps and other facilities and transport facilities, for example, when aircraft and boats come in, that could be different. But we use this information to work out when to get our sample from the sewage. We then had to use the utility expertise to work out how to sample, because it's not always easy to go and sample from sewage. It can be quite dangerous to take samples from wastewater mains that are underground, that are full of gas, and of course full of sewage. So that was quite challenging. And then we set up a system, a standard guideline for taking samples and sharing that information. So we take samples from wastewater plants, from manholes, as well as from auto sampling devices. This is an example of an inline sampler. These membranes here, these membranes are used to capture the virus. They're put inside a plastic sampling device that's put inside the sewer. These are removed every 48 hours from things like quarantine hotels and inline sewers. They're dropped through small entry points into sewer systems. They're currently being sent to our largest quarantine facility in Northern Territory as part of the sampling that's being done in the Northern Territory of Australia at the major quarantine facility there. We can also put in samples from the manholes, and these auto samplers are routinely placed at sewage treatment plants, usually for environmental testing. They're refrigerated and they can be used to capture samples. There's one here from Sydney and one here from Queensland. Across the country, these are routinely put in place at sewage plants already for environmental monitoring. We simply use the same samples for sewage testing. Those samples then taken rapidly to the lab, and where they're kept cold on ice because the virus breaks down very quickly at room temperature, but it lasts for about 2 weeks on ice. The temperatures measured on arrival, the samples are discarded if they've become warm. They then get urgently processed and they're tested. And the testing, the main labs doing the testing originally were the, for the routine sampling, were the SA Water Lab and the Sydney Water Lab. But since then, lots of other labs have been involved. I'll give you a summary of those. So we've got the ALS lab in Melbourne, supported by a whole bunch of research labs. Sydney Water is being supported by University of New South Wales. CSIRO supported by University of Queensland. AWQC in Adelaide, ESR in New Zealand, and PathWest, the Health Department lab in Western Australia. The main labs currently doing the routine testing in Australia and New Zealand. So the sewage samples are pretty dirty and grotty. They've got to be cleaned up. So they get acidified with an acid that's added to them. And then these electronegative membranes are added. We're now using negative, not positive, but it's a minor change to the method published in 2005 in China. It's basically the same method. We use a bead beater to break the membranes up to release the virus. We then get a clean extract, and the clean extract is put into a PCR machine, a molecular technique. This is a Sydney Water Lab using their PCR machine. And in some labs, like ALS, can now do 250 samples a day. They've got a robot analyzer and a robot sampler, and this is the final step being done by a human. But they've got a robot kit now that can do 250 samples per day for the Victorian government across Victoria. A wide range of methods are being used. I won't read them out, but if you want to look at this later on, the National Measurement Institute of Australia collated the methods that are being used and did a trial to compare them. And there are a number of different methods being used, including the polyethylene glycol method that's recommended for WHO for the polio testing, which is a standard method, as well as a number of other methods that have all been published for virus recovery, for RNA extraction, and for PCR. Just want to note a couple of things. Both the United States CDC and the China CDC primer kits work very well. I should also note that it's not published on this trial because it wasn't part of this trial, but the Hong Kong University primer kits also work very well. So the University of New South Wales uses the Hong Kong University primer kits. They work very well. And the benefit of the Hong Kong University one is they've got the longest amplicon, which means you can sequence it more easily. So the China kit, the US kit, and the Hong Kong kit all work very well for this work we've done. And the Europeans use the Eurosurveillance kit. They all work fine. So there's no particular right or wrong answer. The labs do vary, but it's interesting that this shows a summary from the NMI study. The lab performance varies between labs and between methods, but all the methods can be made to work well. This is a summary of the Australian study that's about to be published. There's also a large US trial that has been published comparing methods. So if you want to try a different method, you can look at those studies and see which methods work best. The next stage is reporting. So I'll give you an example from Victoria, because they were the first centre to set up a public-facing reporting system. So Rachel Poon from the Health Department set up a public-facing reporting system. Nick Crosby from Melbourne Water used the GIS systems that Melbourne Water had to get us a way of displaying the results on a GIS system. And they have polygons for each sewage network. And Jim Black's an epidemiologist developed a way of relating that to clinical cases. So they have a public reporting system that they publish. It'll tick if there's no cases, a cross if there's been no test, and a scary sign if there's been a positive result. Across the state of Victoria on a weekly basis, they publish those results. So this is a way of reporting the results to the public. So they take sewage testing around the state and report to the public. There's a similar example here from a media release from where the sewage testing was found in Apollo Bay. So Apollo Bay is down in regional Victoria on the coast. They found a positive test. It's a popular holiday resort. The government published that on the internet, and they told people to go and get tested. And so this has been a common pattern in Australia. We find positives occasionally in remote locations. Airlie Beach in Queensland, for example, had a similar result, and the public were told to go and get tested. And then they did, and they responded well. So it was been a good system. In a number of cases, we have found patients that were positive after pushing and promoting this. In other cases, we never find out who was responsible for the outbreak or the case. This is the New South Wales example. They have a weekly surveillance report. This shows for a range of sewage treatment plants, it shows red for positive and green for negative. It allows the community to see what's going on. And the reason we publish this is to provide confidence to the community so they can see we're testing, and also helps to inform travel decisions between the states. We've got, as you can see, lots of positives for Bondi and Malabar, which are where the quarantine hotels are in Australia and New South Wales. But most of them are negative for most of the regional areas like Blue Mountains and the smaller towns around New South Wales. So you can see the difference between those results. So it's very useful for government to know where to focus its testing efforts and where to focus its communication. What we're now working on is detecting variants. We're using a lot of Perkin-Elmer kits in Australia, and Perkin-Elmer has now released a variant detection kit, a next generation sequencing variant detection kit. We're now trialing that in particularly in Melbourne, Sydney and Brisbane and Adelaide. We're trialing that kit at the moment, and on different methods are being tried, having some success, but it's got issues with sensitivity. But anyway, that's something else we're trying to do at the moment, work out which types of variants are in our sewage. We've also published a good practices guide that's being shared. And the next stage we're doing with that good practices guide is sharing it with the region. So we've got a government grant from the Australian Water Partnerships that we heard from Anne about that earlier on, about the work she's doing in PNG. This particular grant covers sewage surveillance with Thailand, Vietnam, Laos and Cambodia. Myanmar is currently not involved because of the coup there, but they might come back in later on. So we're currently publishing the methods in a form, and we're tailoring the methods for use in these 4 countries. So that's going to be an interesting next stage. I'll just thank quickly all the partners. There's too many to mention, but lots of water utilities, health departments, laboratories, researchers, and international and national collaborators. And then just give a quick email. Kelly is the project director if you want to contact Kelly with any questions. And as I mentioned earlier, we've got a collaborator in Hong Kong with Gary at the Hong Kong Environmental Protection Department, working with Hong Kong University on a similar program in Hong Kong. I'll just finish there.
Okay, thank you. Are there any questions? Just get a microphone across.
Yeah, thanks very much for that very, very interesting presentation. Really enjoyed that. 2 little items, really. I was just wondering, you mentioned it briefly in the last sentence about the sensitivity of the test. You know, how do we know that the test is picking up the COVID? And secondly, if we accept the fact that it's in the sewerage, do we think that it may be making its way in less developed countries, for instance, into the food chain? So are we checking the food chain at all?
So for your first question, we found we've got a paper that's just been published by Jim Black from the Victorian Department of Health and Human Services. He did a very detailed study looking at the specificity and sensitivity of the test. His view is the test is quite specific. We don't get many false positive results. We don't get very many detections that turn out to be a spurious result. So if we find the virus in sewage, it's normally actually in the sewage, but it's not very sensitive. We can often have clinical cases that he knows about from his health department database in a catchment, but we don't see their virus in the sewage. And ESR in New Zealand did work taking lots of samples from quarantine facilities on the same day, and they showed that maybe 4 out of 5 will be negative, 1's positive, and they know there's a patient in that quarantine facility. So you need to do quite a lot of samples and really get your sampling right, otherwise you're going to miss it. So it's specific but not very sensitive, and that's the limitation of the test. As to your other question about transmission, the World Health Organization position is we're not yet seeing transmission of the virus, even in developing countries, through wastewater transmission routes. The virus is very rapidly degraded. I'll give you an example. Charles Gerber, one of the world's leading virologists, discussed his experience with coronaviruses early on in this pandemic. Said if we add coronavirus to just take a coronavirus from a sample and stick it in water, we get 3 orders of magnitude inactivation immediately, just from the phase transition of the virus hitting water. So if you sneeze into the shower, you get a rapid breakdown. The virus doesn't like being in wastewater, particularly because there's detergent in wastewater. And we can't detect the live virus after a couple of days. So even dead virus after a couple of days, let alone the live virus. So I would be surprised if sewage was a significant transmission route at all. in this case. Having said that, you saw the Amoy Gardens outbreak in Hong Kong, and a lot of work done after that. It's highly likely that if you had fresh sewage being transmitted to somebody within a matter of a few minutes to a few hours, you could get transmission. But most sewage is disposed of in a way that avoids fresh sewage transmission, because if you had that happening, you'd be getting ill from everything else: hepatitis A, hepatitis E, norovirus, other adenoviruses. You know, that there are so many much more transmissible viruses in sewage that you would soon get ill anyway by those transmission routes. Coronavirus would be the least of your worries.
Okay, any other questions? Kevin Lowe.
Hello. Hi. Hi, Kevin here. I have one question for Malcolm and another question for the sewage. So I'll ask the second question first. I'm pretty sure you heard about the news, or is it a paper that people find in Italy sewage, they do some kind of tracing and then find that there were COVID-19 fragments back in 2019. So given that the virus didn't stay that long, as you say, it's very fragile, how is it possible that people could find virus samples for such a long time ago? And are you planning to do something similar in Australia to find out when did the virus come to Australia? And I got a question for Malcolm if he's here. I'm quite interested in the concept of is it hierarchies of control? Thought is quite neat, but can you give a bit more, elaborate a bit more on the second option, which is substitutions? I didn't really get what does that mean. Can you give an example? Thank you.
So I'll give a quick answer to that. It's a very simple question. It's a good question. We have a lot of frozen samples, frozen at -80 degrees, going right back from well before the pandemic, from Melbourne and Sydney. We haven't yet analysed those. They're seen as very precious samples. They were being gathered and frozen for the norovirus and adenovirus program. But they've been kept frozen until after the pandemic and we have some spare time. Then we'll go back right the way back for 6 months before the pandemic, taking those samples and see if we can find the virus RNA. So by then we'll have the perfected methods, we'll have time to do that properly, and we'll see when the virus first appeared in the wastewater. So the example you mentioned from Italy and Spain, other countries, they have similar programs where they take samples and freeze them for epidemiological reasons. They've been looking in frozen samples. So you definitely can't find the virus in 6-month-old samples unless they're frozen. But the reason we can find old viruses is because we freeze the samples.
Malcolm?
Yeah, thanks, Kevin. Look, the hierarchy of controls is a sort of generic process to apply across a whole range of hazards. Not as applicable, that level of control, for something like COVID. You can't just substitute COVID for some other infection or some other disease. But it certainly has application in other workplace hazards. So, for example, with asbestos fibres, that they were phased out, and other insulation materials that didn't develop those fibrogenic carcinogens were brought into place, like synthetic mineral fibres and so on. So different levels of that hierarchy controls have different applications across different hazards. I think for COVID, the main one is isolation, engineering controls, administrative changes, rather than the substitution one.
Hi, great. I have a question for Sophie. So I would like to ask, how do we know if we control too much? Like, is there a way to know we're actually overstepping the necessary measures we need to take in order to control the virus? Like, is there any criteria there or measurements there that we're actually considering we are going too far? Thank you.
That's an excellent question. If only it's the wisdom of Solomon. It's a very difficult thing to answer. Have the controls been too much? There's no doubt that they were very severe and have been because of the seriousness of the virus, and using more that objective. We knew that it's highly contagious, and as the science progressed, that was confirmed. I think the measures, whether it's too much, it's certainly effective, because the effectiveness is judged that I think some of the outbreaks have not progressed as much as people expected, so that the social distancing worked. Whether that's fair enough to sustain, given the impact on the economy, is hard to say, though the economy is actually doing all right in Australia. So that would be the other measure: is business suffering too much? Well, yes and no. I think that the evidence showing that if it gets out of control, it has a high impact on business confidence and community confidence. That's the alternative measure, and it's very typical of public health that you sort of don't have a classic way of testing the efficacy of your measures as much as you would like. So I'm sorry it's not a clear answer, but it just indicates how hard it is to evaluate in such a short period of time, at any rate. And at the end of the day, I think people are relying on our success, that we have actually controlled the virus, and they're satisfied with that. Partly the measure of the level of community support, which should remain strong.
I want to just make a comment, Bernie, wrapping up things.
Go ahead.
I can't hear you.
Sorry, I thought you were trying to ask a question.
Oh yeah, no, I just wanted to make a comment. In Australia, we've just noticed now that we are allowed to move around a little bit because we don't have big community transmission, just the value of all the science that was done and all the rapid response. Now that we're actually beginning to talk to each other, there's a lot of the transdisciplinary benefits are really going to sort of pay off now in collaborations going forward about how do we fine tune these scientific methods, the surveillance, to really be helpful to the regulators, to give that in-time response, to guide public health actions. And the water industry has done a great job with the Colossus project. But I'm just seeing in Australia, we've got a very good open sort of conversations happening between regulators, scientists and industry at the moment that has been spurred on by, it's one of the good impacts of this pandemic, I guess.
And actually, the pandemic's changing habits as well. It goes on to the social science side of the conference, I think, because many habits are changing. I work from home far more than I used to. I suspect that will continue going forward. The other thing I think generally is everybody needs to get together, and we're doing it now, but not just worrying about this pandemic. This is going to happen again. That we need all the to be able to scale up coronavirus vaccinations much more quickly, response times, and we need to keep notes on what's happening as a pandemic's going on, so that we can help avoid another. Well, we'll get another one, but minimise and respond much more quickly. Any other comments? We'll finish off. If not.
This is a request on my behalf, Bernie. From this 2 days, I think these sort of transdisciplinary conversations are really important. And I'd like to know at the end of these 2 days, if we come up with, are there 1 or 2 grand challenges that really reflect a transdisciplinary perspective that we could sort of come up with, that we've identified over these 2 days? Going forward, what are the big challenges in terms of applying transdisciplinary knowledge to address COVID? It'd be a nice thing to come up with if we could.
We have a final roundtable session, and that's where that kind of aspect will come. I've been making notes there on things that might be relevant in an overall sense. So we will come back to that on the final session. I forget what time that is. Kevin.
Hello.
Yeah, I have a questions about socio-political responses or changing habit that strike me as interesting, and the question for Sophie especially is that you mentioned one of the changes COVID-19 brought to the governments is the pace, the speed of policy making. You mentioned you used to take years to make a policy, and now you just do whatever, you just try, right? And I think it works. So do you think it's going to be a long-term change? There will be a momentum to expedite the policy-making process?
I think, yes, it did change what I call a bureaucratic time frame. You know, one bureaucratic year is equivalent to 4 ordinary years. It was exhausting. I don't think we could keep it up. But I thought there were several things out of it. I think the point that an understanding across government that their policies have impacts across and building up those relationships hopefully will endure for some time, though they did need maintenance. That will help speed it up to a point. I'm not sure. I think it's a question of priorities. So I've seen things languish and take years to come to fruition because nobody really cared that much about it. It needed to be done, but it wasn't a high priority. And this was just a case, I think, of priority. So I'm not that confident it will speed things up to the same extent as you might hope. Though some of the technologies might remain. But as we're picking up the point, the most important thing out of this, I think, is Bernie's point about, well, what have we learned and how do we put in place something that's sustainable over the longer term? Our Public Health Act is very difficult to use and really needs change and needs to have some thought about how to redesign it, given it was truly, truly used. All of the aspects of it were truly used for the first time since its inception. And it was found wanting, it was found to be bureaucratic and heavy-handed. So in that sense, some of those things will endure, the things that have cut through, some barriers were broken about who can do what with, you know, the role of various agencies and the roles of various people. The relationship with health and safety is one that's changed, I think, forever. Which I think is good or long term. But no, I think the policy process, I don't necessarily recommend it as fast as what happened because there are too many hidden or negative effects unintended consequences that you would have liked more time to evaluate. So a little bit of that caution is a good thing.
The other general thing that strikes me is that it's hard to do in the middle of a response, but there needs to be a more coordinated international response. That when it broke out, the questions of releasing information, some of the genome got out very quickly, but then countries went into self-protection mode. Even Schengen in the EU, they broke down into individual countries. So there was very much a self-protection. There was no planetary-wide effort to try and help others not catch it, but help others to not catch it.
The only other aspect I would say with that is that it was so busy, extraordinarily busy, people working, you know, long hours just to get through, that the first thing you had to do is make sure your local patch was sorted. And that was an enormous amount of work for governments everywhere, I'm sure. We wouldn't have been atypical in that regard. So that builds a little bit of isolation in its own right, because you haven't got that much time. I remember during the course of it, I barely had time to talk to my colleagues in every other state in Australia about what they were doing. We said, oh yes, we must talk as we said, you know, as we rushed, but it was 3 to 6 months before we had time to talk to each other again, because we were all so crisis ridden for so long. So part of that is a function not necessarily of attitude of I don't want to collaborate. It was really a case of I haven't got the time. I'm just still, you know, my minister's wanting this. We need this sorted. We need a brochure on something or other. An outbreak's occurring here. Oh, we forgot to do something about, you know, putting things in other languages. Everything was crisis for 9-10 months. I'd say they're probably steadying the ship now, but yeah. So that's kind of bred isolationism in my view.
Well, I think that's
Sophie, just picking up on Sophie's point there, I think some of the things in the index that we were looking at reflect those things about if we reflect now and pick up on what are those critical things that we need, like relying on overseas supply lines when there's no flights, and being able to communicate things in many languages, all of those capacities and abilities. That's what we were trying to pick up with those sub-indices of the COVID index. And half of them we don't have metrics for, but by brainstorming across disciplines, Lachlan and I were able to, we brought in immunologists and engineers and planners and people from colleagues from Queensland Health, when we came up to identify those factors. They're just sitting there in that factor list, but as research happens now, we might be able to get some measure or metric that reflects those and direct our efforts to strengthening those things to be ready for the next one. Like Malcolm said, this isn't going to be the end of it. And if we can learn from this one and use those sort of indices to sort of predict and strengthen, I think it will be in a
These, hopefully they'll retain some strengthened public health capacity. At least people know that we need epidemiologists in this world. Nobody could even say the word a year ago or 2 years ago. And environmental health officers and in contact tracing. Everybody says it now. They think it's easy, but everybody says it. And they even know that there's sewage surveillance. Who would have thought? You know, so there's some. That's been really good at showing these new things have come in that everybody's valued, and hopefully that will stay on for a period of time. So some of the things put in place.
Any other comments? We should be finishing off, I think. And there's a little message, can't quite read at this distance. Okay, I think we'll close the meeting at that point.